I think that the next quantum change in the management of patients with rheumatic diseases is not going to be a new drug. I think that the next quantum change will be personalized medicine. And the way that I think that ultimately personalized medicine will function is that we will have either biomarkers or cytokine markers or genetic markers that will give us approximations as to what the likelihood of success with a given therapy will be. So if I have a drug that's approved for rheumatoid arthritis or psoriatic arthritis that has a 90% chance of being effective, I'm very much more likely to use that than a drug that has a 30% chance of being effective. It's been a challenging arena with regards to creating these biomarkers or genetic markers to predict response, but one that obviously is generating a lot of research. The other point that I would make about these biomarkers, and something that's not frequently spoken about, but I think is as important as predicting response, is predicting safety. So if I have the same therapy that has a 90% chance of being effective in a patient with rheumatoid arthritis, but has a 95% chance of being associated with a serious infection, even though it's going to be so effective, there's no way that I'm going to use it. So I think that these biomarkers that we're looking to develop have to address not only efficacy, but as importantly, safety as well. And when that era comes, I think it'll make the management of our rheumatic diseases much easier. Co-manifestations and comorbidities are different, or at least I think of them as different entities. For example, let's take rheumatoid arthritis as an example. So a comorbidity of rheumatoid arthritis is the consequence of having an active inflammatory disease that's not being controlled. For example, in rheumatoid arthritis, I would argue that a comorbidity would be osteoporosis or premature cardiovascular disease. Whereas a co-manifestation is a distinct, separate entity that may or may not be related to inflammatory disease. So a co-manifestation of rheumatoid arthritis would be scleritis, the disease in the eye that now is infrequently seen because we manage rheumatoid arthritis so much better. Since these conditions, the co-manifestations, are not that frequent, they're not usually parts of clinical trials. And we do have to understand that particularly with regards to co-manifestations, that there's a different response to different approved therapies. If we continue with the concept of scleritis as an example in rheumatoid arthritis, there is data, for example, that rituximab, the B-cell targeted therapy, is effective in patients who have scleritis, whereas there's not much data for targeted synthetics or other cytokine-driven therapies. There are case reports, but not very much. So with regards to these co-manifestations, I think the rheumatic disease therapeutic landscape differs depending on which co-manifestation you're talking about. Whereas comorbidities are really more, at least in my mind, a consequence of uncontrolled inflammation, and therefore, if you control the disease process, you're less likely to have them. So premature cardiovascular morbidity is affected by controlling the disease process and may be equally affected by different types of therapies. Same thing with osteoporosis.